going to be kind of narrating you through today as Dr. Fullop does our ACL presentation surgically. Obviously, you've all had an opportunity to meet different members of the surgical team. So hopefully this is a pretty realistic demonstration for you all today. Can I see a show of hands who all in this room has had an ACL tear? Oh, quite a few hands. Who knows somebody that's had an ACL tear? There we go, just about everybody. So it's a pretty common procedure, I mean, that we see. And so we're going to guide you through this today. We are typically able to do this as an arthroscopic procedure. So what that means is that small stab incisions on the knee, we're able to use a camera and instruments to complete the procedure, which it helps lower the risk of developing scar tissue, knee stiffness, things along those lines. So the arthroscopic advancement here has been a huge advance in this procedure. Can you still hear me? Okay now. Yeah, so just so nobody gets weirded out as we get ready to expose the knee here, this particular body does not have a lower leg, so just to let you know that the foot is missing, but the advantage of this is a fresh knee. I mean, the tissues are still viable, and we're able to complete the procedure for a good demonstration. So once again, everybody met. This is Sabrina Waldrop. She is one of our surgical techs. She helps hand in hand. Dr. Fullop, obviously, is our surgeon. And this is Chelsea, Kayla, and Beth. They're our physician's assistant. We all work together on this. We all have a role in this to make this an efficient procedure. So, we've talked a lot about, a lot of times our athletic trainers are ones that send these patients to us if they've had an on-field injury. We've spent a period of time in the office where we evaluate you. A lot of times, we have to get an MRI scan that confirms that the ACL is torn. The other thing is ACL is not a surgery that you want to rush into. There's a TV commercial that I see, and they talk about an ACL is rushed to the hospital in an ambulance and they book them for surgery. That's not at all what happens. An ACL surgery is done after swelling subsides, when a patient's regained their range of motion. If not, you're going to set yourself up for having a stiff knee that really there's nothing to do about at that point. So what we're demonstrating today is the point where we've diagnosed the ACL, the patient has regained their range of motion, their swelling's down, and now it's time to do an ACL reconstruction. Now, a lot of times I'll hear people say, I'm going to have an ACL repair. It might be just getting hung up on words, but a repair would indicate we would go in and stitch the ligament back together. The problem is when an ACL ruptures, its fibers just shred apart, and there's no going back and stitching that back together. There's not a blood supply that would allow that ligament to heal. So we call it an ACL reconstruction, and that means we have to take a graft from somewhere and fashion that into the new ACL. So can we get the projection up on the? Okay, gotcha. So what Dr. Fullop's doing, it's a very systematic approach to the ACL. So we start by just doing a standard knee arthroscopy. That just means going in and assessing the structures. So that means looking at is there any damage to the articular cartilage that caps into the bone? Is there any meniscal injuries? There is a very, very high incidence of meniscus injuries with an ACL. Now, what the meniscus is, there's two C-shaped pieces of cartilage. You have one on each side of the knee, and those are the kind of like shock absorbers between your thigh bone and your shin bone. When those are torn, there's kind of a vast treatment on that. Sometimes we can fix those, and sometimes the way our bodies are designed, the meniscus has a poor blood supply. So if we were to fix it, it wouldn't heal, we would re-tear, and we'd have to take you back to the operating room. So, the majority of the people that we're doing ACL reconstructions on are younger. We want to preserve as much cartilage tissue as we can. So, we try to preserve that if at all possible, but sometimes, unfortunately, that's just not the case. So Dr. Fullop's taking a look around the knee. You know, we typically, like I said, we look at the meniscus, and I'm going to be honest with you, this might sound very basic. We always confirm that the ACL is torn. I mean, you can tell, MRIs are really good at telling us that there's an ACL torn, but I've heard horror stories where a surgeon has harvested a graft going to do the ACL and the ACL is intact. I mean, that'd be your worst case scenario. So, I mean, we confirm that that ACL is torn before we ever do any other part of the procedure. I'm going to try to address a couple of these extra credit questions while we're working on the feed here, so just so I don't miss any of them. So, does anybody know? Obviously, we're talking about ACL. That's the anterior cruciate ligament. Does anybody know what two ligaments cross in the middle of the knee? Yeah, our athletic trainers all shoot their hands up. I'm glad you guys know that. So I'd be worried if you didn't. So there's the anterior cruciate ligament, and then there's the posterior cruciate ligament. So that's, for the, I can see Ken's writing very feverishly here. So, does anybody know what cruciate means? What's that, Rachel? Cross. Very good. So, so the anterior cruciate ligament prevents the tibia from sliding forward on the femur. So it also has a rotation component to it. So that's, you'd be concerned about anterior shifting of the tibia and a rotation instability if you have an ACL tear. And that's why it's so important to have this addressed. Now, for normal day-to-day activities, straight line walking, those kinds of things, you don't have to have an ACL. So that's where, once you start getting, 30, 40, 50, I mean, the indication for doing an ACL reconstruction can certainly go down. And then the PCL prevents the posterior translation, but that's a whole separate procedure. So I will, another thing to address, I talked about we don't repair the ACL. We take a graft from some location and fashion that into the new ACL. Now, there's three main grafts that we use. Dr. Fullop and I use a hamstring graft. So at the beginning of the procedure, once we've confirmed the ACL is torn, we work on harvesting the hamstring graft. Now there's two hamstring tendons that wrap around to the front of the knee, and we're actually able to isolate those and harvest those to fashion in our new graft. A common question I get asked a lot, they're like, well, doesn't that weaken your hamstring? It actually doesn't. There's multiple attachments to the hamstring. And it's something that you still have that function of those muscles even by harvesting those tendons. The other common location is the patellar tendon. So the tissue that goes from your kneecap down to your tibia, that bump called the tibial tubercle, you can actually harvest the central portion of that. And that's another commonly used ACL graft. And some people, in some indications, I think it's less indicated, but some people use strict cadaver grafts as the graft for the reconstruction of the ACL. Sometimes Dr. Fullop and I actually we have to use kind of like a hybrid, like a combination. You want the graft to be large enough and strong enough to withstand the forces that it's going to see. Sometimes people have very small hamstring tendons, just an anatomic variance, and sometimes we will actually take a cadaver graft and supplement that with our hamstrings that we've harvested from the patient to ensure that the graft is strong enough. I'm going to go ahead and kind of talk you through what Dr. Fullop's looking at here. As I said, he started this procedure by doing a standard knee arthroscopy, just assessing what injuries are associated with that. This area that he's right now is called the patellofemoral joint. So that's the fancy word for the kneecap joint, where the kneecap meets the femur. That groove at the bottom is called the trochlea. That's part of the femur bone. and then up above is the kneecap or the patella. If you look at the circle video image, see the little triangle up in the top of the corner? The scope that Dr. Fullop is using has a 30-degree angle on it, so he can actually turn it to look up at structures, turn left, turn right, look down, just to aid him in seeing what he needs to see at each stage of the procedure. So, like I said, he looked at the patellofemoral joint. This is the medial compartment of the knee. So the crescent structure on top is the femur bone. Down below is the tibia, and then that tissue through the middle is called the meniscus, and that's what we talked about. Is similar to the shock absorber between the thigh bone and the shin bone. And you have one there. That arch structure through the central portion there is the meniscus. Does anybody have a laser pointer? That'd be great. Thank you. So he's so this is his probe that he used to help him to assess those structures. Now that probe looks giant, doesn't it? The end of that is 5 millimeters. So if that puts you in any perspective, the size of what we're doing here. So and it's 2 millimeters thick. So that I'm talking about the length of the end of that is 5 millimeters. So that helps us to gauge that. Now he has now gone on to what we call the intercondylar notch. That is the central portion of the knee where the anterior cruciate ligament and the posterior cruciate ligament cross. Now, these fibers, see these shining fibers to the left? That's the posterior cruciate ligament. Now, when we started the preparation today, this patient still had their anterior cruciate ligament, or the ACL, intact. Obviously, we resected that so we could show you the procedure, but it would normally run in that area. Where he can see all the way to the back of the knee. Thank you. Normally you could see all the way to the back of the knee. Normally you couldn't do that because the ACL runs in this direction. So there's 2 attachments to the ACL. The attachment on the femur is on the medial aspect or the middle aspect of the lateral femoral condyle. That may be a little confusing. So when you think of the femur is almost like your typical dog bone that you see. So there's 2 rounded condyles on the end. So the lateral means the one to the outside, but it's on the inner portion of that condyle. So it attaches right here. And then on the tibia, it attaches in this area. That's some of the fibers that we left of the old ACL. And that's oftentimes what it looks like when we get in there. It's just, there's some fibers left, but no substance in the tissue. And there's a spine on the tibia called the anterior tibial spine, and that's where the ACL attaches on the tibia. This device that he's using here is an electrocautery device. It helps to clear tissue away so you can get back to healthy tissue. It also, if we encounter any bleeding during the tissue, it helps us to stop that bleeding so it doesn't disrupt any of our visualization of the procedure. So it's really important to clear away all the torn fibers because the graft that he's going to incorporate will not heal to those old torn fibers. So you want to get it back to healthy bone tissue because there's a blood supply to the bone that allows for the graft to heal into that. We talked about the function of the ACL, preventing it from the tibia from sliding forward on the femur. Now, this device here that he's using is a suction shaver. So it has Dr. Fullop is actually controlling it with a foot pedal that you can't see, and that there's a suction that's attached to it, and so that any tissues that are loose with the suction will actually suction into the device. There's a small blade on there that will oscillate back and forth, and it will debride any tissue that Dr. Fullop is trying to get rid of. It's designed so the backside of it, the blade is not exposed, which is important because otherwise you can do some damage to surrounding tissues that you're not wishing to remove. What's that? Okay, So he's changing now the camera angle to the medial portal, and he's going to start working on the placement for the tunnel and on the femur. So this is a little aiming device. He's using, he inserted this through a very small incision on the knee. Can you show the front of the knee for just a second? So you see, he's doing this through two very small incisions. I mean, they're a centimeter or less. But he's able to insert this aiming guide through that. That's what allows us the technology to do this arthroscopically and not having to do a big open incision for this procedure. Go back up to the... so this device allows him to aim where he wants to put the graft. Might be a little technical, but we, on a left ACL, if you think about this circle image, as a clock, he wants to put the graft approximately in the 2 o'clock range. There's some other specific landmarks that are a little technical that I won't go into, but that help us to know exactly where the ACL normally attaches. And a lot of times you can tell, it looks like maybe right there, there's some fibers left from our resection, so you can look and actually see this is where the ACL normally attaches. The other thing that to mention, I don't know if we want to do any of this. As I said, we start doing a normal knee arthroscopy, taking a look around the entire knee. Once we confirm, yes, the ACL is torn, then we move forward to harvesting the tendon tissue that we're going to incorporate into our graft. Now, we take that, once that tissue is harvested, we actually take it to the back table, and that's where we prepare it, because there's some suture fixation that we have to do that. And that's typically done by our physician's assistant. It really helps us that, less anesthesia time, that they can be working on that part of the procedure while Dr. Fullop or myself are doing the other ACL reconstruction. Okay, so Dr. Fullop is, I said this metal structure in here is his aiming device, and this is going to help him to drill the tunnel where he would like that to come out. So he's got a drill that's actually coming from the outside of the femur, the lateral side, and in a minute you're going to see that drill bit break through. And that's, you can see it aims it right to that central portion of the arc, and that's where he wants that drill bit to come through. So you can see the end of the drill bit there. So once again, sizing, that's a very small end of the drill bit, but it looks really big on the screen. So, like I said, what he's doing, we call it a tunnel. The tunnel is the recess in the bone where the graft will be sitting. And like I said, you want that to be a pretty tight fit because you want that tissue that we've harvested to grow into that bone to secure that, and that's what gives you a stable knee. So it's called a flip cutter. What's that? Yes. So once it flips, then he'll spin that with the drill, and that will ream the size of the tunnel that he wants for his graft. There's going to be a lot of debris in here. That's where that suction device is very helpful. It'll clear up here in just a minute. Like I said, these are bone fragments that he's reaming out, that ultimately the graft will be passed into. Put in his suction device here, and that's going to allow him to clean up all this debris that was generated when when he reamed that tunnel on the femur. The other thing, not only does this, I talked about how this suction device will oscillate back and forth to cut like soft tissue. He can actually direct it with that foot pedal one way or another to, sometimes you actually have to remove a little bit of the bone on the femur just so that graft doesn't impinge and rub and ultimately lead to an increased risk of a re-rupture. So that's something that, those devices are amazing. They do a really good job. So you can see that's the tunnel up through the femur. So this is all around here. This big tunnel is the tunnel that the graft is going to fit in. Now we'll talk about here in a minute. Keep in mind this smaller hole. It's what we use to fix the femur with something we call an endo button, and I'll explain that as we go along here. Let me show them quickly how they're fixing the graft. So like I said, this is real life. Kayla and Beth do this during procedures. There's a suture fixation that we need to go to the graft. So this is actually a cadaver graft that we sometimes use to supplement it, but it looks very similar to the tissue that we would use if we harvested it from you as a patient. So this is the suture that she's using here. It's called a fiber wire. I mean, it's extremely strong stuff. I mean, it's not breakable. I mean, it's very, very, very strong. Kevlar, yeah. Kevlar is the actual substance. It actually, when we tie with it, sometimes it's kind of weird how it happens, but it doesn't cut your gloves, but it'll actually cut your fingers. A lot of times when we're done with this, we'll have little cuts on our fingers when we're done that. Let you know you did an ACL that day. So they typically do this needle fixation. They typically do 5 throws of the suture on each end, and that allows us to secure that graft and to pass it, which you'll see as we proceed on here. So, any questions so far? I know it's a lot we're throwing at you, but. Okay, question, one of the extra credit questions, I think that's got all of them, and if we get that one addressed. Yeah. So it says, following ACL reconstruction, the earliest return to sports is approximately how many months? So the answer to your question, I would say, is 6 months. It can actually be as long as a year, sometimes even longer than that. So once we incorporate the graft, it's really strong, but the way that the body incorporates the graft, it actually becomes weaker in the 2 to 3 month mark after surgery. I always caution my patients that this is a time that you need to be very, very critical and diligent of what I tell you what your restrictions are, because that's the point in time where you're at a highest risk for re-tearing your ACL. Because you feel good, your surgical pain has subsided for the most part, your range of motion is good, you feel like, hey, I can get out and do things. But that's when your graft is the weakest. If you push your envelope before you're ready, you're going to be at a high risk for a re-tear. Then after that 2 to 3 month mark, the graft starts strengthening back. And that's when you really start hitting your physical therapy hard. I mean, it's a very intensive therapy regimen. Ultimately, we try not to use just a time period to say that every patient at 6 months, or every patient at 9 months, or every patient at 12 months can go back to sports. A lot of it is based on their strength and how they've recovered, their range of motion. Our therapy department has actually put together it's what we call like a return to sports assessment. So when I have a patient that I feel is getting ready to return to sports, we'll put them through that assessment. They measure the operative leg versus the non-operative leg. There's a lot of criteria, and the legs need to be within 90% of each other on these measures. So the earliest is 6 months, but it can be longer. And a lot of that just depends on how intensive you are in your rehab. Now you see these NFL stars, some of these guys return return to NFL in 6 months, but that's their job. That's all they do is rehab all day long. So, so that's moral of the story. Follow your restrictions extremely closely and work extremely hard on your therapy. That will reduce the amount of time that it takes you to return to sports, but 6 months is the earliest. Okay. Okay. All right. So Dr. Fullop is now progressing on to creating the tunnel on the tibia or the shin bone. So this is another aiming device that he has that allows us to direct a guide pin in. Which you can see he's just a small incision that he's going to make. He's marking the skin with the device. He's going to take a scalpel, make a small incision. He spreads with scissors just to make sure he doesn't do any damage to any, nerves or blood vessels underneath the skin. Then he advances this little aiming arm. You can see kind of right behind his hand, and that aiming arm comes up in contacts or comes into contact with the tibia. Now. Yeah, good point. So you see all this water running. There's a saline solution that we run through the knee, and that helps, number one, to what we call like insufflate or inflate the joint, so we can see the tissues that we need to fix that. It also helps keeps the clarity of the image on there. If we did not have that saline running through the knee, it'd be a very blurry image. It'd be very difficult to see what we're doing. So you can see he's now taken the guide pin and directed that into his joint where he wants the tibia. So I told you here earlier, this is the PCL right here, these fibers. There's some different landmarks, but you want the graft to be approximately 7 to 8 millimeters in front of the PCL or the posterior cruciate ligament. It's also very important the angle that he has of this guide pin to make sure that you don't want it too vertical and you don't want it laying too much to the side. So he's got a really nice angle of his guide pin. This is a larger drill bit. It's called a reamer. So this is going to ream out a hole within the tibia that the graft will come through. Now, that varies from case to case. It all depends on the size of the graft. We have a device over here that's the reamer popping into the joint here. We have a device over on the back table that, once Kayla and Beth get done prepping the graft, they're able to run it through this device, and we can say that is a 8 millimeter graft or an 8.5 or 9.5 millimeter graft, and that's the size of the reamer that we use for the surgery. So just for, we normally would have that figured out, but we're just, for the flow of the procedure, we haven't necessarily done that. But they've got the graft prepared here, and then so Dr. Fullop has now prepared the femoral tunnel, for the tunnel in the femur, and the tunnel on the tibia. Now he's using a little grasper, kind of looks like scissors on the end, that allows him to open and close the teeth of this grasper. He's going to grab that suture and he's going to pull it out through one of the small incisions that he made, and he is going to use that that suture, that strand of string, to pass the graft through. There's a lot of different ways to fixate these grafts into the knee. Now, the type that's very common that we use on all of ours that you'll be seeing today is what we call an endo button technique. Now, I don't know how well you can see this, but these endo buttons are a little 10, 15 millimeter piece of metal. As the graft goes through, which you'll see here shortly, we insert pretend my hand is the femoral tunnel. We insert the endo button outside the femur. Is he on that? So that's this little endo button right here, a little piece of metal. So you'll see Dr. Fullop inserting it, but it inserts through the femoral tunnel, it comes outside of the femur, and then we have a way of flipping it to where then it abuts and it lays across the back of the femur. Now, once he does that, you can grab it, you can pull as hard as you want, and you won't be able to pull it through. So it's a very, very small piece of metal, but very, very strong fixation. So now they're taking the graft that had been harvested, that Kayla and Beth had prepared on the back table, and they're attaching the endo button to that graft. Yeah. So this is the sizer that I was telling you about. On the end, you can see it has different measurements. It has, there's 8.5 millimeters, 9 millimeters. So that's a little, so that's about an 8.5 millimeter. And that's kind of the bottom number that we like to use on that. You don't really want to go much less than that, because that just that decreases the strength of the graft if it's too small a graft. As I said, if it's too small a graft, at this point in the surgery, we would have them get one of the Cadaver grafts that we have in our freezer, bring it out thawed, and then we incorporate that into the graft to make it a larger graft to make it stronger. I'm sorry? Yes. Yeah, it's all a big picture that you have to put into that. A smaller person, may take a smaller graft, but if you have a big, like these big, like NFL linemen, you want as big a graft as possible in that. But you have to incorporate that into the size of the notch or the space in the femur to make sure that there's not any impingement. But you also want the biggest graft that you can get. So it's kind of, there's multiple factors that play into that. But yeah, that's. But typically, a lot of the research has shown that less than an 8.5 millimeter graft is too weak. So you can see that suture that Dr. Fullop had passed on the camera, he is now attached that to the sutures that Kayla and Beth prepared to pass that graft. You can see it's getting ready to go in right here. Okay, so you're going to see, this is that little endo button I was talking about. That's it. It has just gone through the tibia. It is now entering the femur. And that's being directed by the sutures on the outside that Dr. Fullop is pulling on. So you see there's that little piece of metal going, it's going to go through that little tiny hole that I talked to it. See, it flips through there. So he's passed the graft all the way. And then he's flipped that button. It's now sitting against the outside cortex of the femur, and it's snug. Like I said, Dr. Fullop can pull on that as hard as he wants, and it's not going to come through. It's very, very strong fixation. Okay, so now this is the graft that's been prepared. It's going to start being advanced now into the femoral tunnel. You can see that's the tissue that Kayla and Beth were working on the back table. That's advanced to the graft, and then so that's where it comes out of the tibia. It's entering into the femur, and then that's what the new anterior cruciate ligament looks like. I talked to you earlier when the tear was there. You can see all the way to the back of the knee. Now you can see that graft is now in place. And functions as the new ACL. Now there's one other thing that the small button is what is fixated that onto the femur. On the tibia, there's several different ways to do it. Dr. Fullop and I typically use there's a screw that screws into the tibia that secures that graft, and a lot of times we'll even use a metal staple as just a backup support to that. But you can use suture anchors, there's these buttons, there's other ways to do it in that regard. So it's kind of surgeon preference on that, Here's them. Yeah. So this is the small screw that Dr. Fullop is going to screw into the tibia to secure the graft on the tibia. Now, they used to use metal screws on that. These are now it's more of like a biocomposite, like ceramic screw that eventually, over time, the body will break down and turn into bone. So, so you might be able to tell where it is, but you actually won't see metal. Like if you were to have an X-ray of your knee after this, you won't be able to see a metal screw like they used to use in there, which is important because if you ever have to re-injure your knee and you require another MRI scan, metal distorts the images of an MRI scan. So if you were to have a metal screw in there, that can really distort the image, and it'll be impossible for you to tell if you've re-ruptured your ACL or whether it's still intact. So he secures that in, and that provides a like an interference fixation of the graft onto the tibia. And like I said, sometimes we use a staple over the remainder of the graft to secure that in, and then once we're happy with the fixation, you just trim the remainder of the graft that's there. And at this point, you'll see a lot of the athletic trainers. If you see professional athletes, there's a maneuver called the Lockmans where you see them pulling the tibia forward on the femur, and that'll be loose at the beginning of the procedure. Dr. Fullop, we're going to do that now. It's going to be rock solid. So that's, and then, so once again, ACL graft, and then, we typically take that through a range of motion to make sure there's no impingement, to where the graft would be rubbing on any of the bone, because that can lead yourself to a higher risk of a re-rupture. Anything else you want to add to that? So at this point, that's the majority of the procedure. We proceed with wound closure. We do occasionally use drains just to help prevent a buildup of blood. There's times we use drains and times we don't. That's a little technical, but if we had to do a meniscus repair, we typically make that patient non-weight bearing. So no bearing weight with no bending the knee past 90 degrees for 6 weeks to allow that meniscus time to heal. If we don't have to do that, the patient can be full weight bearing, bend the knee, truthfully without significant restriction right away. So there's a big difference in that. As I said, in a younger patient, you want to try to preserve as much of that cartilage tissue as you can. So I think that kind of concludes our demonstration here.
So I just want to say here before we get going here, thank you to everybody for coming. A couple things. We did wheel a couple of our We wheeled a couple of the cadavers down from our classroom. I know some of y'all arrived a little bit late, and that's okay. So we brought those down. If you were on a tour and you didn't get a whole lot of time to explore the cadavers a little bit, we're going to extend an opportunity here at the end for you to be able to do that. The only thing I ask of you is this. While it was okay for us to be taking photos of this procedure with the way things that we have set up, the cadavers in the back that have been completely dissected, we prefer nobody taking any pictures with those, of those, that type of thing. I think some of the surgical team, hope I'm speaking okay, will be up here. Andrew Kleinschmidt's over on the side. Some of the other athletic trainers and other professionals might want to come up at this time. If you have any additional questions for them, this would be your opportunity to come up and meet them. Most of our professionals, a lot of them come and speak here at the college, and they're very gracious about making opportunities for y'all to come shadow, to ask them questions about their career. So I encourage you to take time, if your school is not leaving right away, to come up and do that. You'll be able to see things up on stage. Is that okay with you all? And And then we'll have the cadavers unzipped again, no pictures. And on behalf of Wabash Valley College and Wabash General Hospital, we want to thank you for coming today.